Hello students, today we are going to discuss about the newborn of a diabetic mellitus mother. Means if the mother is having diabetes mellitus during pregnancy, how we are going to manage them and what are the symptoms and other causes, okay, that we are going to discuss in this topic. So let's start. Introduction. Women with diabetes in pregnancy type 1 or type 2 or gestational are at risk, increase the risk for the advanced pregnancy outcome. Adequate glycemic control before and during pregnancy is crucial to improving the outcome. And diabetic mother have a high incidence of polyhydramnios. Polyhydramnios means the amniotic fluid will be more, or preeclampsia, that is high BP, or pyelonephritis, preterm labor, and chronic hypertension. Means if the mother is having any type of diabetes, either it will be type 1 or 2 or gestational, there is a more chance that mother can have the high incidence of polyhydramnios or other, this is the condition. Okay, so their fetal mortality rate is greater than that of non-diabetic mother, especially after 32 to week of gestation. Means if the mother is having diabetes, there is a more chance of fetal death compared to non-diabetic mothers. Fetal loss throughout the pregnancy is associated with the poorly controlled maternal diabetes and congenital anomalies. Means if the mother is unable to control the diabetic or sugar level during the pregnancy, there is a chance of fetal loss. Most infants born to diabetic mother are large for gestational age. Means the baby, if it is born also after delivery also, there will be a large for gestational age. Means compared to their gestational age, they will be very big in size. If the diabetic is complicated by the vascular disease, infants may be growth restricted. So if the diabetes is having complication of vascular disease, the child will be growth restricted. Means the growth and development will not happen properly, especially those born after the 37 week of gestation. The neonatal mortality rate is more than 5 times that of infants of non-diabetic mother and is higher at all gestational age and in every birth weight for the gestational age category. Next is definition of gestational diabetes mellitus. Any abnormal glucose intolerance that begins or is first recognized during pregnancy using glucose tolerance test. There are two types, one is type 1, one is type 2. Type 1, also known as juvenile diabetes or insulin dependent diabetes, and is a chronic condition in which the pancreas produce little or no insulin. In the type 2, what happens, it is also known as adult onset or non-insulin dependent, is a chronic condition that affects the way of your body metabolize the sugar, characterized by high blood sugar, insulin resistant and relatively more. So in the type 1, what happens, the pancreas only will not produce the insulin, so you have to give insulin from the outside. But in case of type 2, the pancreas will produce the insulin that our metabolism, our body will not metabolize it properly. The sugar will be not metabolized in the body properly, so for the controlling that, we have to give insulin from the outside. Epidemiology. The harmful effects of maternal diabetes recognized more than 100 years ago. Since the development of specialized maternal, fetal and the neonatal care for the women with diabetes and their offspring, a nearly 30-fold decrease in the morbidity and mortality has been noted. Currently, worldwide, 3 to 10% of pregnancies affected by the abnormal glucose regulation and control, and majority is about 80 to 80%. And for the pre-existing diabetes, it is about 12 to 20%. Infant to mother with the glucose tolerance are at risk, okay, for the mortality, and the growth abnormalities will be there, like either it will be large for gestational age or for the small for gestational age. Hyperviscosity secondary to polycythemia, congenital malformation, hypocalcemia and hypomagnesemia. You see this baby, it is large, the baby is large, okay, plump and plethoric infants of a mother with the gestational diabetes. Clinical manifestation: neonate large and the palm as a result of increased body fat and enlarged viscera with the puffy plethoric faces resembling that of the patient who have been receiving corticosteroids, may be of a normal or low birth weight, particularly if they are delivered before the term or if their mothers have associated with the vascular disease. Hypoglycemia develops in approximately 20 to 50% of infants of diabetic mother and 15 to 20% of infants of mother with gestational diabetes, but only a small percentage of these have the problem. Okay, and neonatal hypoglycemia means level of blood glucose level enough to cause the symptoms in the central nervous system like jitterness, tremors, convulsion, limpness, lethargy, eye rolling, diaphoresis, hypothermia, high pinch cry. In the respiratory system, cyanosis, tachypnea, apnea. In central cardiovascular system, pallor, cardiac failure or arrest. GI system, feeding difficulty. See, these all are interrelated and symptoms can be seen with other diagnosis also. So always keep a different initial mind and consider other diagnosis if the glucose administration does not improve the symptoms. Clinical manifestation, that is respiratory distress syndrome, occurs more frequently in IDM, okay, inward of metabolism, and hyperinsulinemia cause delayed maturation of the surfactant synthesis, and diabetic moms likely to go into the premature labor, hence greater risk of having immature lungs at birth, and transient trachypnea of the newborn, that is occurs more frequently in IDM because of risk factor associated with the having diabetes, prematurity, macrosomia, birth asphyxia, polycythemia, increased likelihood for C-section, okay, and causes by delayed reabsorption of the fetal lung fluid, mild pulmonary immaturity and mild surfactant deficiency, and it is usually resolved within 72 hours of life. Next, in the neurological, what are the symptoms you can see? Anencephaly and spina bifida occurs 10 to 20% more frequently, and caudal regression syndrome, okay, these are the symptoms you can see in the neurological. Okay, next, in the GI anomalies, like so many congenital malformation you can notice, and like you can see renal agenesis and other urinary tract abnormalities. In hematological, you can notice polycythemia or hyperbilirubinemia. So the management for the baby with diabetic mother: follow blood sugar, the first important thing. Next is, if it is SGA or LGA, also check hematocrit value. Further workup and management depends on the patient clinical presentation and physical examination. If it is hypoglycemia, early feeding or IBF with the dextrose. Symptomatic electrolyte abnormalities, replete electrolytes. Respiratory distress means cardiopulmonary support. Okay, hyperbilirubinemia means phototherapy. Polycythemia means IBF, hydration or exchange transfusion. Neuro GI or genitourinary abnormality means imaging studies and specialist consult. See, these are the treatment that will plan based on the symptoms that we notice in the baby. Next is prognosis. The morbidity and mortality lessen with the adequate diabetic control during pregnancy. Means the morbidity rate and the mortality rate will be less if the mother can control the sugar during pregnancy. If the diabetes is poorly controlled, there is a high risk of neurodevelopment defects in the baby. The risk of CP and epilepsy is increased. The risk of childhood obesity and diabetes and the metabolic syndrome also increase. So this is how you are going to manage the baby with the diabetic mother. Thank you everyone.